Yeah, as Christine introduced, I'm a data scientist at XU. So if you don't know our company, yeah, we are mainly working for pain and opioid care. So currently we have some open position. If you are interested, let me show. Yeah, so we have we are looking for finance manager, like director. So we have some analytics specialists. So yeah, also have a EMR integration engineer. So we have a couple analytics role and engineer role. If you are interested, yeah, you can just contact me. Yeah, I can refer you to my company. So. All right. Yeah. Today I'm going to talk about machine learning and prediction in medicine. So yeah, mainly I'm going to show a graph here. So how many do you familiar with Gartner? Yeah, I know a lot of it. Yeah, they know. So Gartner have this hyper cycle for any emerging technology every year. So in 2016, they put machine learning. Yeah, if you see here, yeah, machine learning is at the top of that. We can call it a plateau. So what the Gartner analysis shows that machine learning would be in plateau in 2 to 5 years. Yeah, as they predicted in 2016, which means right now at the end of 2018, so machine learning is just at the top of all the technologies. So it's really hard. But following this trend, there's a potential machine learning will go down, right? Go down to the trial disillusionment, and also go back to the whole slope of enlightenment. So that way, we have to really talk about the capabilities and the limitation of the machine learning at this point, so we can learn better what the machine learning can be used in medicine. Yeah. All right, so my presentation today will mainly focus on 3 pieces. One is the capability of machine learning in medicine. Then the limitation of machine learning, and some solutions. So today, there's no demo, you don't need to type any code. So just follow on. Feel free to ask me any question. First let's have a look at the capability of machine learning in medicine. The most important one in the past few years as machine learning is emerging. So the machine learning can improving dramatically the prognosis of the diseases. So for example, as the data nowadays, all the EHR, we have collected all kinds of data, and also claims. All the claims built for the health plans. So all the data, there's really a lot of different variables you can use as predictors. So that's really rich data there. And so some other use can be used as identify metastatic cancer patients. As this technology improved, it really can identify this cancer patient precisely. Another use is all these algorithms, as they predicted, will be coming into use in 3 to 5 years. as Garner predicted. So that, yeah, another capability of machine learning in medicine, yeah, is mainly they can, as probably some of you already know, yeah, especially in the radiology and pathology. So they were saying all this new technology will replace all those radiologists and anatomic pathologists because they are mainly focused on reading all the imaging. So all the new algorithm come up can replace this specialists. Yeah, there's also a report that says in recent years, especially this year, the medical students who choose radiology as a specialty has been decreased. So they are concerning this machine learning, artificial intelligence, will be replacing them in the future. So also the most important one, as I highlighted here, right? So all the machine learning is on the computer. That's machine. So they don't need to sleep. Yeah, they can work 24/7. Yeah, very accurate. So it's much. So that can be replaced a lot of work. So another capability of machine learning in medicine, as we probably a lot of you already know, is improve the diagnostic. So the algorithm we use nowadays, we can really suggest the high value tests and also reduce the overuse of testing. As in my company, for example, we use the algorithm, machine learning algorithm to predict the OUD, that's opioid use disorder. So we can help the provider identify this patient early. Yeah, that's one of the use here. So any questions so far?
Yes, what was the disorder you just mentioned?
Opioid use disorder. Yeah, it's a dependence on opioids. Oh. Yeah, like painkillers. Yeah. So. Yeah, that's I mentioned all the capability of machine learning in medicine. So I got this cartoon here. Yeah, can you guys see the conversation there? So when in the bottom says when handing radiology over to artificial intelligence sounds appealing, but this computer was asking, I'm being sued for a misdiagnosis. What do I do now? So the doctor says, sorry, buddy, come with the jobs, right? You have to take it. Yeah, that's nowadays a lot of clinicians or the provider or the companies, they are not ready to adopt all this technology because they have been concerning, what about the legal issues, right? So that comes with all the limitations. Now let's look at the some of the limitations of the machine learning. First one is mainly diagnose. In medical world, it's mainly just diagnose. If you can predict, you diagnose correctly, right? That's the most important thing. But for machine learning, especially in medical field, there's so many there's so many diseases. There's no golden standard, right? So if you are not able to define a golden standard, how can you define the diagnosis is correct or incorrect? So another issue is with the EHR. As we mentioned earlier, the GHR really have all the data coming in, all the patient data, in different ways. But majority of the data stored are unstructured format. It's difficult to use. So that's another difficulty here on machine learning. In diagnose, in this domain, a lot of, as we know, in the medical field, all the different diagnose, you have to build a model specific for that diagnose. You can't use one size fits all, right? So even at my company, we are building fighting opioid epidemic, but the cause of opioid epidemic is varies. Majority of patients come from different pain. Either you come from back pain or you come from other surgery. So for each pain type, we have to dig into figure out what's the cause of that pain, so we can build a robotic algorithms. Now let's see another side of the limitation. It mainly focus on the prediction. So currently, majority of the machine learning is based on the history data, right? All the current data you have. If you don't have the data of the prediction you want, they are not able to present any predictions. So especially for clinical data, as the study shows that the clinical data alone, is really difficult for predict hospital admission. You have to combine this clinical data with all other information collected for the patients, right? That's one of the challenges, kind of like in my company right now, because majority of our data is from administrative data, other claims from the health plan. So right now we are trying to get all other related patients' personal EHR data to be integrated with our administrative data, right?
Well, how do you tell when there's enough data to make it? I was talking to a hospital system last week,
right?
And they were talking about a particular condition they had. And, they had 9 hospitals and 7,000 employees, not small. And there was certain thing they were interested in. There was only 23 patients last year. And so, 23 data points.
It's really small. Even for single clinical research, 23 patients, is really small sample size. But you have to try, get more sample first, right? But what kind of data do you have for the patients?
It was just anecdotal, we were talking about, and I don't have specifics. They haven't solved this problem, I was just wondering, when you were putting up there about, well, you can't squeeze something out if there's no information present. How much information is enough to pull something out? And I don't know the answer to that.
I'll come to the solutions later, so I'll show you, what kind of data we need. Right? So still there another point on the prediction. So study shows that accumulating multiple years of history data is worse than simply just the most recent year. They said that when your goal is to learn how medicine should be practiced, the relevance of clinical data, the half-life of the data is just about 4 months. So.
You're saying that, like the most recent 4 months for each patient, or for all the entire population?
On the sample, you are building the model. So, which means,
Oh, go ahead.
Mainly if you can just use the most recent year, that should be fine. Yeah, we know especially in medical field, the policy changed very frequently, right? From plan to plan, so from year to year. Probably 3 years ago, the data is not very useful now.
So why is that? Why is that such a? It seems pretty short because working in insurance and all the underwriters are usually asking for 3, 4, 5 years data.
Mm-hmm. As I mentioned, the one main point, is the health policy change frequently, right? The policy from plan to plan, from year to year, even months, they probably come up some new, decisions. So, it will affect the data points.
So you're talking about clinical data.
Right.
But you're saying policy changing quickly, but medical science does not advance very quickly. The data, clinical data, related to the nature of the disease should be relatively stable. So why only?
Also, that's another side of the provider, how they practice medicine, changed year to year.
Jay, this is a very interesting observation. It strikes me that there are some forms of data which would not necessarily change. For instance, genetics. I'm not sure that would change in that kind of time. But in terms of the types of medications that are used, procedures that are, this is a technological field that's changing, and that's something like that. Those instances make sense. I'm less surprised at that number. It's severe.
I think for probably in our practice, when we do analysis, we can just start working on 1 year data, build your model, see how the model works. Right.
I'm sorry, I see something in this when we develop the model. At the beginning, I think the model will learn based on diagnosis made by human, by doctors, maybe, and then we just build up the model. But what I see is as we progress, because the more recent data is generated by the model itself and not by human anymore, as we go forward, we more rely on the data that's produced by a model, not by a human being. So as the model is progress, it will start more relying on self-generated data rather than learning data that's coming from the human being decision. Is that a true trend? Like, does it
it's another trend. I'll talk about it later in an example. So it's mainly here you can think that as for your model, if you build a model in 2016, right? In 2017, you probably should retrain your model based on the new data you get. As you said, the model will also create some new data. So for 2017, you should get all the new data in, to retrain your model instead of use the old model build in 2016.
Sorry. It also occurs to me that the type of machine learning algorithms you're using would have an effect here. So for instance, if you're doing, say, linear regression or something, some form of regression, you have fixed coefficients. So once you establish that, they don't change. But if you're using something like genetic programming or Bayesian techniques, those are adaptive. So over time, as you're seeing changes in the data, those routines should adapt.
Right. I agree with you. So, this is just a journal. It's not for a specific, method. So, Any other questions? Here is another point, on the prediction. So, to assess the usefulness of the models, we must evaluate the accuracy in predicting future events. As I mentioned earlier, a lot of times the model we build is mainly based on to summarize the history trends. So we really should think about how to predict the future events. So these are all the limitations I mentioned here. So I'll give you an example. Very famous example here. So how many have you remember the Google flu trends? Right. So they built the model in 2009, and they retrained the model by the end of 2009. So that the blue line here is the Google flu trends. The red line here is the CDC numbers. So as we can see from 2010, 2011, 2012, seems that model works really well. In 2013, there's a huge gap between the Google prediction and the CDC numbers. So what's wrong here? That's what they were thinking about. Do any of you guys know?
SARS.
SARS, probably is one reason. There's from a technical side, the main reason is Google stopped retraining their model from 2009. So they only updated their model once here. In all this year, they are still based on the old model. As I mentioned earlier, probably you should retrain your model every year with the new data coming in. Right? They didn't capture all the new information. That's why in 2013, there's something, unexpected happened. So now let's look at the solutions. So the main point here, you have to get all kinds of data, right? And you have the question early. So what kind of data should we have for your 23 patients, right? So if you can get all the social demographic patients, personal genome information, all other related sensors. So it's more like if we can get more data around our patients, that will be, we can build a profile with this personal patient. So that's now we call it either precision medicine or personalized medicine. We really want to get as much as data we can for each patient. Another thing on the machine learning, mainly this question applies for all analysis. So when we do analysis, we really need to reframe the question first, get a clear answerable question, right? We can bite one question at a time. We don't want to deal with a huge issue. Otherwise you get lost. So for example, here, I mentioned that there's an example. You can ask a question, will you have a heart attack within 10 years? Right? Also, you can ask if you have a heart attack within 1 year, if you can predict that. So we have specified, make the question answerable, that the machine learning can build on it. So another point is here, we can predict the events early enough. So this is how early is enough. It's a really tough question. So this question you have to talk with your clients. If your clients are all clinicians, you really have to talk with them. See how they use their data every day. What's their question have? So help you figure out the timeline you need to build on your model. So these three are the main solutions come up. So that's basically all my presentation today. So I'll just show you the last slide here. So if you want a second opinion, I'll ask my computer. Yeah, that's what we are going to do next in the future, right? The clinician. This tells the main point here for machine learning in medicine. We really have to combine this technology with we call it a software, right? Or the machine learning algorithm. But we need to combine this software with the hardware. What's the hardware? That's a clinician, the provider. So their talents. So we have to combine this together, to do a better work in the healthcare field. Instead of just use machine learning alone, it's impossible just use this technology alone to do all the things in healthcare, right? So, yeah. Thank you. Any question? Yeah, go ahead.
Are you familiar with the GNHA All of Us program? Have y'all seen that?
See that again?
NIH.
Yeah, I know.
Is doing a program called All of Us. And their goal is to take medical records for 1 million people.
Mm-hmm.
And it includes genetics, lifestyles, environment, health records, all of that. And I don't know what their projection is in terms of how long they think it'll take. But Vanderbilt is a part of this.
Yeah, I know Vanderbilt is part of the precision medicine initiative, right?
Right.
Yeah.
So I guess my question, I just want to make everybody aware of that. And, and by the way, you can volunteer your data. So if you believe in this, then sign up to sign up. All of us. At any rate, how much of access to genetic data do you have in building your models? And have you figured out a way to use that?
In our company, we don't have any access to the genetics yet. So
we had a conversation the other day about it. One of the problems is nobody pays for genetic testing. I mean, or it's personally paid for. And so none of the healthcare insurance plans are paying for it, although it's sounding like there's a whole lot more. On a personal level, your personal genetics. And I haven't seen yet where the EHRs are starting to incorporate it.
I got to tell you, the idea that the insurance companies have access to our genetic data scares them to change.
You've seen where they caught criminals from these 23andMe type sites.
Really?
Third cousins, like people committed to crime, will put their DNA in, and they'll compare the third cousin's DNA with the crime scene, and then they'll look at who lived in that city in that year when that crime was committed, and they found people from their cousins they probably didn't even know.
Based on the DNA test?
Yeah.
But I don't know what the insurance.
Mingjian, do you want to comment on the our project? I'm asking. He's working at the Precision Medicine Institute at Vanderbilt. So
It's open test initiative, and we will get all 1 million people, the lifestyle, and also the final goal is to get whole genomic data and analyze them and get information about which genetic they have related some pieces.
Yeah.
And also providing their lifestyle, environment, with the relation of this disease.
Yeah.
So
They're talking about Fitbits too, or something like that. Monitoring devices.
yeah, they have some like the wearable data. That's your everyday lifestyle. So it changes and more predict your health condition.
Yeah.
Yeah. So it's kind of integrate several area data. Your genomic data, your health condition, and all the other. Yeah. Actually, it's very promising because we have more data like this big database, and with computing ability, maybe we can get something from this big data.
Oh,
Yeah.
Is this data available to like healthcare companies? Like are there already like companies using like genome data in their analysis?
I'm not very familiar with this kind of company. Yeah.
Just issued.
Mm.
Yeah. So right now, you can recruit people here. Yeah.
Yeah, the NIH one is a federal funding. Yeah, it's not a private company. So.
that's what it says.
Mm-hmm.
There's no business case if the government doesn't.
Right.
But to my best understanding, government is involved. They are not working with the state government. They are very strict to protect data that comes from the data that help to identify people. Their network, the way they protect the data is very strict in the networks.
And it will be in this case. That's the only way.
Yeah.
That's the only way to get people.
Yeah.
So they believe.